For today's case, it is the case of DM, which is a 60-year-old housewife with a history of type 2 diabetes, hypertension, hyperuricemia, hypothyroidism, and hyperlipidemia. She sought to consult due to episode of hypoglycemia. The patient is currently on medication which includes losartan 100 mg, atorvastatin 40 mg, febuxostat 40 mg, levothyroxine 75 microgram, glimepiride 4 mg. All are taken once daily. For the past medical history, the patient have already underwent cholecystectomy and total thyroidectomy. Moving on to the physical examination of the patient, BP is 140 over 90, indicates that the patient is hypertensive. The rest appears to be normal. However, the BMI when computed is 30.2, indicating that the patient is in obesity class 1 category for adults of their height. EENT is unremarkable. Chest and lungs shows clear breath sounds. Heart, point of maximal impulse at fifth left mid-clavicular line, and no organomegaly is noted. Neurologic exam, equal reactive pupils, no gaze preference. For the extremities, normal tone and strength of all extremities. So for the laboratory exam, urinalysis showed that an abnormal or increase in measurement of the protein and glucose. Hematology came back normal. For the blood chemistry, the parameters in red indicates an increase which shows that the patient fasting blood sugar, hemoglobin A1C, creatinine, cholesterol, triglyceride, LDL cholesterol, and thyroid stimulating hormones are increased. The thyroid stimulating hormones may be attributed to the total thyroidectomy that the patient underwent. It was also noted that the patient HDL cholesterol is decreased and the ECG of the patient shows normal results. Lastly, for the management, glimepiride was shifted to sitagliptin or metformin 50 over 500 milligram tablet twice a day and was advised to follow up after 2 months. She was also advised to lose weight, minimize consumption of food with added sugar, and do daily exercise, and also to stop cigarette smoking.
So now moving on to the pathophysiology of diabetes mellitus. Depending upon etiology, we can divide it into two types, type 1 and type 2 DM. So for type 1 DM, it was previously termed as juvenile onset diabetes, or it was called insulin dependent DM. It constitutes for about 10% of the total cases. The basic phenomena in type 1 diabetes is destruction of beta cell mass, usually leading to absolute insulin deficiency. While its causes remain idiopathic, there are three mutually interlinked mechanisms behind its happening, which are genetic mutations, such as concordance in identical twins for around 50% and susceptibility gene on HLA region in chromosome number 6. Some autoimmune factors like islet cell antibodies, CD6, CD8 plus T lymphocyte mediated beta cell destruction, and certain environmental factors, ultimately leading to type 1 diabetes. For type 2 DM, previously it was called maturity onset diabetes or non insulin dependent diabetes. Patients with type 2 DM require insulin therapy to control hyperglycemia or to prevent ketosis. It constitutes for about 80% of the DM cases. Unlike type 1 diabetes mellitus, alongside genetic factors, other constitutional factors such as obesity, hypertension, low physical activity, and some medications such as corticosteroids, antipsychotics, and progesterone only oral contraceptives also contribute to the development of the disease. The basic metabolic defect is impaired insulin secretion in insulin resistance. These both are interlinked in response to insulin secretion and resistance. In response to insulin resistance causing the hyperglycemia, there is compensatory increase in insulin release to maintain the normal blood glucose level. So, as a part of insulin resistance by the peripheral tissue, the liver also shows insulin resistance. In spite of hyperinsulinemia, in early stages of the disease, gluconeogenesis in the liver is not suppressed. This results in increased hepatic synthesis of glucose, which contributes to hyperglycemia in these cases, ultimately leading to type 2 diabetes.
For the pharmacodynamics of the drugs, first we have the losartan. It is an angiotensin receptor blocker which reversibly and competitively prevents angiotensin 2 binding to AT1 receptors in the tissues. Adverse effects includes angioedema, hyperkalemia, and renal impairment. It is also teratogenic and causes less cough compared to ACE inhibitors. It is contraindicated in angioedema, hyperkalemia, hypotension, renal artery stenosis, and hepatic or renal impairment. It is a category D drugs and not recommended in breastfeeding moms. Next, for atorvastatin, it is an HMG-CoA reductase inhibitor which blocks an enzyme needed by the body to make cholesterol. So as a result, it lowers the amount of cholesterol in the blood. It can cause hepatotoxicity and myopathy and is contraindicated in hypersensitivity and concomitant use with the strong CYP3A4 inhibitors. It belongs to category X and can be used by breastfeeding mothers. For febuxostat, it is a xanthine oxidase inhibitor. This drug decreases uric acid production by inhibiting xanthine oxidase. It can cause liver function abnormalities, diarrhea, headache, and nausea. It is contraindicated in patients being treated with azathioprine or mercaptopurine. It is also a category C drug and can be used while breastfeeding. Moving on to levothyroxine, this drug is classified under thyroid hormone preparations, which is a synthetic hormone form of T4 and it is used for the treatment of hypothyroidism. The mechanism of action of these drugs involves activation of nuclear receptors resulting in gene expression with RNA formation and protein synthesis. Overdose can lead to hyperthyroidism, angina pectoris, tachycardia, palpitation, atrial fibrillation, and menstrual irregularities. The drug is contraindicated in patients with thyrotoxicosis, acute MI, pancarditis, acute myocarditis, and untreated adrenal insufficiency. It is classified under category A of teratogenic risk and is compatible with breastfeeding.
So next drug we have glimepiride, which can be classified under sulfonylurea. The mechanism of action for the same is that it reduces the blood glucose via stimulating insulin release in beta cells of pancreas and decreases glucose output from the liver. The adverse effects for the same could be weight gain, hypoglycemia, hemolytic anemia, and the drug should be contraindicated in those patients who have severe renal or hepatic impairment, and those who have hypersensitivity to glimepiride or to sulfonamides, and those who have type 1 diabetes as well. Under teratogenic risk, this can be classified under under the category type C, and for breastfeeding, the drug should not it is not usually recommended while breastfeeding. Next, we have sitagliptin, which is classified under dipeptidyl peptidase 4 inhibitors, and it blocks the degradation of GLP-1 and increases the circulating levels of GLP-1. The adverse effects of this drug is that it can cause nasopharyngitis, it can lead to headache or upper respiratory infections as well. It should not be given to those patients who have any known hypersensitivity against sitagliptin. And under teratogenic risk, it is classified as category B and it is not recommended to use while breastfeeding. Lastly, we have metformin, which is classified under biguanide or biguanide, and the mechanism of action is that it is one of the antihypoglycemic agents which improves the tolerance of the glucose by lowering the basal and postprandial plasma glucose. The adverse effects could be that it can lead to vitamin B12 deficiency if used for a very prolonged period of time, and it can also cause lactic acidosis, loss of appetite, asthenia, nausea, vomiting, and diarrhea as well. For contraindications, the drug should not be given to those patients who have acute or chronic metabolic acidosis. And under the teratogenic risk, the drug is classified as category B, and it can be used in minimum amounts while breastfeeding.
For the pharmacokinetics of the drugs, first we have the losartan, which has an oral bioavailability of 33%. The volume distribution of losartan in the active metabolites is about 34 liters and 12 liters respectively.
Losartan is metabolized to an aldehyde intermediate, E3179, which is further metabolized to a carboxylic acid. And a single dose of losartan leads to 4% recovery in the urine as unchanged losartan and 6% in the urine as an active metabolite. Following losartan is atorvastatin. It is very rapidly absorbed after oral administration. The reported volume of distribution of atorvastatin is of 380 liters. Atorvastatin is highly metabolized to ortho and para-hydroxylated derivatives and various beta-oxidation products. Atorvastatin and its metabolites are mainly eliminated in the bile without enterohepatic recirculation. Next is febuxostat. After oral administration, about 85% is absorbed rapidly. The apparent steady-state volume of distribution of this drug ranges from 29 to 75 liters, indicating a low to medium volume of distribution. It is metabolized in the liver and eliminated via both hepatic and renal pathway. The fourth drug is levothyroxine. Absorption of orally administered T4 from the gastrointestinal tract ranges from 40% to 80%, with the majority of the levothyroxine dose absorbed from the jejunum and upper ileum. T4 absorption is increased by fasting. Levothyroxine has a limited volume of distribution, and approximately 70% of secreted T4 is deiodinated to equal amounts to 3,3 and reverse T3, which is sclerogenetically inactive. Thyroid hormones are primarily eliminated by the kidneys, and a portion of the conjugated hormone reaches the colon unchanged and is eliminated in the feces.
For glimepiride, it is rapidly absorbed from the gastrointestinal tract, with nearly 100% bioavailability. It is highly bound to plasma proteins and primarily metabolized in the liver via CYP2C9 enzymes. Glimepiride and its metabolites are mainly excreted in the urine. Clinically, it helps manage blood glucose levels but may increase the risk of hypoglycemia. Next is sitagliptin, which is also rapidly absorbed with approximately 87% bioavailability. It has a moderate volume of distribution and minimal hepatic metabolism. The drug is primarily excreted unchanged in the urine with minimal fecal excretion. Sitagliptin improves glycemic control without causing hypoglycemia. Lastly, metformin is rapidly and completely absorbed with a bioavailability of 50 to 60%. It does not significantly bind to plasma proteins. Unlike the two other drugs, metformin is not significantly metabolized in the liver. It is predominantly excreted unchanged in the urine, with minimal fecal excretion. Metformin's insulin sensitizing properties make it effective in type 2 diabetes.
Now we move to the indications and effects of the drugs. First, we have losartan. It is indicated to treat hypertension, lowering the risk of stroke in people with hypertension and left ventricular hypertrophy. It lowers the blood pressure by blocking the action of angiotensin-aldosterone system that leads to the dilatation of the blood vessels and the inhibition of the reabsorption of sodium. The next drug would be atorvastatin. It is indicated to treat dyslipidemia in adults, hypertriglyceridemia, primary dysbeta-lipoproteinemia, and hypercholesterolemia in adolescents. It lowers blood sugar by stimulating the pancreas to secrete insulin. When there is too much sugar in the blood, it also alerts the liver to stop producing sugar. Next would be febuxostat. It treats hyperuricemia in adult gout patients. It is a xanthine oxidase inhibitor that works by causing less uric acid to be produced by the body. The next one would be levothyroxine. It treats primary thyroidal, secondary pituitary, and tertiary hypothalamic congenital or acquired hypothyroidism. It restores the normal levels of thyroid hormone, regulating metabolism and energy levels.
Next is glimepiride, which is prescribed to manage type 2 diabetes mellitus. It lowers blood sugar levels, enhances glucose utilization, and increases insulin sensitivity. This medication improves glycemic control, thereby reducing the risk of complications such as cardiovascular disease and nerve damage associated with diabetes. Sitagliptin is primarily prescribed for type 2 diabetes mellitus to enhance glycemic control. Its effects include lowering blood sugar levels by stimulating insulin secretion from the pancreas and inhibiting liver glucose production, which thereby reduces the liver's output of glucose into the bloodstream. By addressing both mechanisms, sitagliptin helps to improve overall glycemic control, thus alleviating symptoms associated with high blood. And lastly, metformin, which is primarily indicated for the treatment of type 2 diabetes mellitus. Its effects include limiting liver glucose production and enhancing insulin sensitivity. So, by reducing the liver's glucose output, metformin helps lower blood sugar levels, especially during fasting periods. And additionally, it improves insulin sensitivity in peripheral tissues like muscles and fat cells, thus facilitating more efficient glucose uptake from the bloodstream.
This concept map outlines the different drug classifications used to treat diabetes mellitus. So, without further ado, let us first start on insulin anti-diabetic drugs. First are rapid-acting drugs. These three insulin analogs are insulin lispro, insulin aspart, and insulin gluticin, have rapid onsets and early peaks of activity that permit control of postprandial glucose levels. Second are the short-acting drugs. We only have here regular insulin, which is used intravenously in emergencies or administered subcutaneously in ordinary maintenance regimens, alone or mixed with intermediate or long-acting preparations. Third are the intermediate acting drugs, which include neutral protamine hagedorn insulin or NPH insulin, or also known as isofane, which is a combination of regular insulin and protamine, a highly basic protein also used to reverse the action of unfractionated heparin that exhibits a delayed onset and peak of action. Fourth are the slow, long-acting drugs, which are insulin glargine, insulin detamir, and insulin degludec, which are modified forms of human insulin that provide a peakless basal insulin level lasting more than 20 hours, which helps control basal glucose levels without producing hypoglycemia. And lastly, we have insulin combinations of both short acting with 25 to 50% and long acting with 50 to 76%. Now let's proceed with non-insulin anti-diabetic drugs. First, we have insulin secretagogues, which stimulate the release of endogenous insulin. The first group, sulfonylureas, includes lirpropamide and tolbutamide in the first generation, and glyburide or glibenclamide, glipizide, and glimepiride in the second generation. Next, we have non-sulfonylureas, or meglitinides, which include repaglinide and eteglinide. The second class comprises biguanides, with metformin being the primary member, reducing glucose levels by inhibiting hepatic and renal gluconeogenesis. The third class consists of alpha glucosidase inhibitors, acarbose, miglitol, and voglibose, which act in the intestine to inhibit alpha glucosidase, slowing carbohydrate absorption. The fourth class are incretin modulators, includes glucagon-like peptide 1 or GLP-1 receptor agonists, such as exenatide, lixisenatide, dulaglutide, liraglutide, semaglutide, and abiglutide, along with dipeptidyl peptidase 4 or DPP4 inhibitors like alogliptin, linagliptin, sitagliptin, vildagliptin, and saxagliptin. The fifth class are thiazolidine diones, includes rosiglitazone, pioglitazone, and troglitazone, enhancing target tissue sensitivity to insulin. Next, we have sodium glucose transporter 2 or SGL2 inhibitors like canagliflozin, dapagliflozin, empagliflozin, and ertogliflozin. Reduce renal glucose reabsorption, causing glycosuria and lowering glucose levels. Additionally, pramlintide, an amylin analog, suppresses glucose release, slows gastric emptying, and reduces appetite. Lastly, we have colesevelam, a bile acid binding resin, bromocriptin, a dopamine receptor agonist, and some motostatin analogs including octreotide, lanreotide, and pasireotide. Thank you for listening. That would be all for our pharmacology workbook exercise 4 for anti-diabetic agents. This is Group 3 signing off.